Hi, good afternoon, everyone. I'm gonna start the presentation in a minute. All right. My journal club discussion today will be on the crash trials. So, for now, there are three crash trials. As we know, crash one in 2001. Crash 2 was published in 2013 and Crash 3 was on 2019, which is the most recent, but they only reviewed their full report recently, I think about 2 years back, right? So Crash 1 was talking about corticosteroids, or more precisely was on methylprednisolone, all right, on significant head injuries patients. Whereas Crash 2 was about tranexamic acids, evaluation of their effect on death, vascular occlusive events, and also transfusion requirements in bleeding trauma patients. Whereas Crash 3 was on the effects of tranexamic acid on the death, disability, vascular occlusive events, and other morbidities in patients with acute traumatic brain injury. So we just need to bear in mind for Crash 1, it was a negative finding. Crash 2 was the positive finding. And Crash 3, it was supposed to be how to say, a negative finding, but somehow they managed to uh, split the data into sub-analysis group and come up with a positive uh, outcome. So we're going to look more in details one by one, yeah? All right, so on Crash 1, they actually study on the effect of intravenous corticosteroids on death within 2 weeks, which is 14 days, in 10,000 plus adults with clinically significant head injuries. So we just need to bear in mind for all these landmark trials, they're always definitely randomized clinical trials, double-blinded. It has two arms, one arm of intervention and one arm of control. And usually the sample size are huge to be able to have significant power to come up with statistically significant data. So every studies or trials always come with a first question first. So in this crash trial, when they started, they wanted to know in adults with a head injury, do early corticosteroids compared to placebo? So whenever placebo, we will use normal saline to compare, but all the studies are double-blinded, which means the one who give, the one who receive, and the one who collects the data will not know which is which. Okay, they want to know whether this will actually reduce death and disability. So their design was they calculated based on a statistical power and for the intention to treat analysis. And based on that, they come up to what is the amount of patient size they need to collect in order to receive or collect the data that they want. So in the end, from the calculations, they managed to get about 20,000 patients that they were supposed to recruit. However, the study stopped after 10,000, and later I'll explain why. Right? So based on this data that they collected from 239 hospitals for 49 countries, and it was from a duration of 1999 to 2004. And majority of the data collected actually from Europe country, but there was also from Asia. So why do they collect from different countries? Because they want to compare between the low income group, middle income group, and also the high income group. All right. So from the population and the inclusion criteria, it must be an adult of more than 16 years old with head injuries, presented within 8 hours of the injury with a GCS less than 14. So the exclusion criteria is whether there's a clear indication or contraindication for steroids, whichever that benefits or endanger the patient, these patients are not to be taken as a sample size. All right. So this was the form they needed to fill in. Not too sure whether you can see, but basically they just want to get all the data that they can collect. from the patients, even their demographics, okay? And the main part here, they actually use the GCS. So how do they consider who to recruit or who not to recruit? So first, when you receive a patient with traumatic brain injury, everyone is a potential eligible patient, all right? As long as it's more than 16 years old, it's within the 8 hours of injury with not full GCS. So based on that, the doctor that attend to the patients have to decide whether this patient has absolute contraindication or indication for steroids. Either group, the patients are not to be recruited. Other than that, is to be included. So this is very interesting because most of the time in trials, we don't really have the inclusion criteria as the physician being uncertain. But for all crashes trial, one of the criteria is actually when the doctor cannot decide whether this is going to be beneficial or non-beneficial, and it's actually an inclusion criteria to include this kind of patients. Then they'll call and it will be computerized randomizations to place the patient into the steroid or a placebo group. Okay? So they basically want to know whether the effects of the high-dose corticosteroids on death and disability, is it going to bring more harm or actually is going to benefit? And they want to know whether the effects of this kind of steroids infusion may increase the risk of infection and GIT bleed. As all of us know, high steroids, these are the possible complications, as we can always see in our COVID patient. All right, so the regime in the intervention group is they were going to administer methotrexate for 48 hours. Initially, they give a loading dose of 2 grams over 1 hour and 100 mils of normal saline. Then they maintain 0.4 gram per hour for 48 hours. So whenever they pack these solutions, it will be ready packed and labeled. However, they will not mention whether it's a control group or interventional group. They will just write there as pack, crash trial pack, and whether what number or sample size it is. This is what we call a double blinded, because the person who treats and the person who take the medication and the person that receive do not know whether they're in a control or intervention group. So the outcomes that they measure is from the primary outcomes, they actually measure the death from 2 weeks of injury, and then subsequently death or independence at 6 months. So their point of treatment will be at 2 weeks and 6 months. All right. So it's quite simple in recruiting because just now we mentioned is the form where you want to recruit the patient. Sorry. And then subsequently these two forms, which is the early outcome form and also the subsequent 6 months after they recovered from the head injury. These are where they collect all their data. And interestingly, they actually measure Glasgow outcome scale. I think all of us are very familiar with Glasgow coma scale, but not many of us are aware of this Glasgow outcome scale. So here you can actually see that as the score is higher, same like our GCS, the better it is. The score is lower, it means poorer outcome prognosis. So from this first crash trial, they actually came out and they stopped it by, as I mentioned in the beginning, they needed to recruit 20,000 patients to get a significant power or statistical analysis. However, by the time they recruit 10,000, they already started to unmask their patient because there was already significant difference, and it actually favored placebo in terms of mortality at 2 weeks. So you see the corticosteroid groups has a higher percentage of mortality, which is 21%, compared to placebo, which is 18%. And the relative risk was 1.18, which means that anything that is more than 1 actually has a poor outcome or means increased risk. So because of this, the study cannot be continued because in any ethical committee, whenever you can find harm to the patient, you're not supposed to continue anymore. All right. And by the 6 months follow-up, they actually find out that the study also actually favored placebo. Hence, metupred is no longer a practice to give for traumatic brain injury patient. Okay. So this is a simple data that we show. All right. So they showed at a 2 weeks mortality and also 6 months mortality. So significantly, you can see in corticosteroid group, the percentage is higher. All right. 21.1% versus 17.9%, whereas in the 6 months mortality was 25.7% to 22.3%. All right. That is why the study stopped after 10,000 patients halfway through, right? Okay. For those who are maybe unfamiliar with all these evidence-based studies, I think it's important for us to know what is a confidence interval, what is p-value, what is relative risk or absolute risk reduction, and number needed to harm. I'm not too sure whether here the absolute risk reduction, I think this is actually absolute risk increment, but they are published, so I think they are right. I'm wrong. So in confidence interval, it actually shows that your patients, 95% of your population means will fall below between the lower and upper limit, which is within the bell curve, yeah? Right? For example, if in relative risk ratio or risk ratio, this is how we calculate, okay, the incidence of outcome exposure over the incidence of outcome without the exposure. So you just need to know that RR, if equals to 1, means there's no risk. Whereas RR more than 1, there's increased risk of outcome. Hence, CRASH 1 was stopped after 10,000 samples recruited. Now we move on to CRASH 2. So if you remember, CRASH 2 is regarding tranexamic acid compared to CRASH 1, it was regarding corticosteroids. But it's still in the same trauma patient, however, not the traumatic brain injury patient. Okay, so why they come up to think about tranexamic acid use was they were thinking and postulating that on the hypothesis that surgical patients and traumatic patients actually go through the same mechanism as in bleeding. Hence, they want to know whether tranexamic acid will bring benefit. So initially, if all of us know tranexamic acid belongs to the antifibrinolytic group, yeah? So what else medications within the group? Famous, the ones that we know are aprotinin and aminocaprylic acid. However, aprotinin was too expensive and it's really not that feasible. So for all these landmark trials, you need to actually take it from all different type of income countries. So aprotinin may be very available in US, however, it may not be available in Tanzania, which is one of the countries that they actually did the CRASH 2 study on. Hence, it was not selected. So they decided to use tranexamic acid, yeah? So the clinical questions, whenever there's a trial, they want to come up with questions. So in trauma patients with or at risk of significant hemorrhage, does the early administration of a short course tranexamic acid actually affects the mortality or the incidence of occlusive events and the amount of blood transfused? Because we will notice in our practice, whenever we want to prescribe tranexamic acid, you get the medical specialist or the physicians to come and tell you, hey, this patient is non-STEMI, this patient MI, probably not that suitable for tranexamic acid, right? So this study actually gave us an answer as well. So they actually looked into the effects of tranexamic acid on the death, vascular occlusive events, and also blood transfusion. So before we go into it, I probably just do a simple introduction. Some of you may not understand why how does the tranexamic acid works. So if you look at our diagram, very simple. You have a cut at your skin. So there's a damaged endothelial cell. So this damaged endothelial cell actually release a tissue plasminogen activator. So this will actually activate your plasminogen to bind with fibrins and lysine at their binding sites. So when they bind, the tissue plasminogen activator, plasminogen, and also fibrin actually form a complex, and this complex leads to plasminogen activation to plasmin. Okay, plasmin will degrade the fibrin to fibrin degradation products, and hence the clot will be released. But tranexamic acid's mechanism of action, they are actually a synthetic analog of the amino acid lysine. So they actually takes the lysine binding site and prevent the plasminogen form activating to become plasmin. All right. Hence, there's no degradation of the fibrin, and they believe that because there's no degradation, these fibrin-rich clots will stabilize and hold longer, which they postulate will actually helps in hemorrhagic patients. So for the design of CRASH 2, same also, they randomize using a 24 hours free call center with a center. They give information in the beginning, and then based on this block size is how they put the patient and how they randomize using a computerized system. And then they will tell that your patient takes what, whether pack what number. But all these pack are blinded, all right? So it's a multi-center double-blinded placebo control with identical treatment packs, all right? So, and same, they did the calculations, and if they need the studies to be effective with a statistical significance, they need about 20,000 patients as well, okay? So same, they collected the data from 274 hospitals in 40 countries, which these 40 countries included the low income, middle income, high income group. So for example, in the studies that they gave was Tanzania was the low income country because Tanzania belongs to probably the poorest 15 countries in the whole world. And then the middle income country was India and the higher income country was USA. All right. So the enrollment began in May 2005. Yeah. So for the inclusion criteria, they take age more than 18 years old with trauma present within 8 hours of incident with significant hemorrhage by systolic blood pressure less than 90 or a heart rate of more than 10. And same also, the responsible doctor was substantially uncertain. So this is very interesting because when you're not sure, you can recruit this patient. All right. So the exclusion criteria was very simple, same like CRASH 1, clear contraindications or indications to tranexamic acid. So you might think, what are the contraindications to tranexamic acid? So I just attach here some of the contraindications. So commonly are hypersensitivity, PE, DVT, MI, CVA. So this one, because there's a potential harm, so ethical wise, it's not ethical for us to recruit this type of patients into the study. Hence, they are considered to be excluded. All right. So interestingly, they actually reported that there are patients that actually violate some of the protocol. But the good thing was both arms actually have equal and match. So there's no bias in that way. Right? So the intervention was very simple. In the intervention group, the tranexamic acid was given in loading dose 1 gram over 10 minutes, followed by an infusion of 1 gram over 8 hours, whereas the placebo group also with non-saline only. So the outcome from this was a primary outcome and secondary outcome. So in a primary outcome, they actually measure death in hospital within 4 weeks of injuries. And then they actually find that there's a significant reduction in the intervention group. Whereas in the secondary outcome, there was no significant difference in intervention and control group. in the terms of blood product transfusion, surgical intervention, or occurrence of vascular occlusive episodes or blood products transfused. And this study actually measured them up to 28 days, yeah? So this is a data that I put in a summary. So the ones that I highlight, you can see in the death by subgroup, yeah? So in the bleeding, in interventional group, the bleeding risk was 4.9%, whereas in control group was 5.7%. And this p-value was actually below 0.05, so it's significant. Hence, that's why I say CRASH2 is a positive trial that came out with the result that we wanted. And people may worry about the outcomes or side effect of it. So if you look down on the blue color circle, there's no symptoms or no difference in the control and tranexamic acid, all right, with significant p-value. So a conclusion that we can get from this study is tranexamic acid safely reduced the risk of death in bleeding patients, okay, bleeding trauma patients. Hence, we actually consider for use, all right? So each study has their own strength and weaknesses. So for CRASH2, for all landmarks, they actually are randomized, double-blinded, and we assume that it's very low in bias, yeah? Okay, and usually their sample size are very big, significant. However, in this CRASH2, there's some weaknesses, all right? As in, randomization is based on subjective opinion of treating physicians. So sometimes some physician may actually know, but they will just say they are not certain. Then they will include the patient. So they think that this might pose some selection bias. All right. So in this trial also, they actually didn't stratify the injury severity, whether besides this systolic blood pressure and heart rate, how many organs involvement, was there a long bone injury, they did not mention. And the follow-up period was only 28 days. They think this is incomplete. They felt that could have been longer, all right, to get the follow-up. Next, they felt that there's no standardizations on the amount or choice of fluids or blood product used. They only mentioned the transfusion, but they did not give in details how much was transfused, all right? And only 5% of patients in both groups actually died of hemorrhage. So now we go to the last and most recent, which is a CRASH3 trial. So now we know first CRASH trial was on corticosteroids. Second trial was on tranexamic acid. So now, based on these two trials, they tried to combine it and find the effect of tranexamic acid on death, disability, vascular occlusive events, and morbidities in patients with acute traumatic brain injury. All right? So same, what was their question? So their question they wanted to ask, in patients with traumatic brain injury, does the administration of tranexamic acid under 3 hours from injury compared to placebo actually reduce head injury associated in hospital mortality within 28 hours? So we always know that the first insult, there's nothing much we can do, but we want to prevent the secondary insult. So this was what they had in mind. But the initial study was actually 8 hours from injury, but they revised it to 3 hours from injury throughout the second half of this trial, because when they started to have the data, they already started analysis. So let's look into it, yeah? So the background is they think that traumatic brain injury actually, all of us know whenever we have traumatic brain injury, their mortality and morbidity is actually high. So what they wanted to look into this is if there is a significant reduction in mortality and morbidity, even in 2%, for example, in the total population of traumatic brain injury patient, it will actually affect up to probably 10,000 patients. And they think that this is very significant for the amount of patients that will make a difference. All right. So if you know there's another TIC2 trial, they actually look at the use of tranexamic acid in spontaneous intracranial hemorrhage, but not traumatic bleeds. So we know that traumatic bleeds can be classified into probably four kinds of bleeds, yeah, based on the location. Whereas take two only look to intracranial bleed. So all this actually didn't give them the data they did want. And the small trials that were set in India, Colombia, and Thailand, their sample size is relatively small, which is only 500. So they couldn't have the statistic significance to actually change the practice in our daily practice or evidence-based practice. Yeah. So the design, this is just a very detail of how they're going to do it. They actually randomize the patients, they put the labels. If those who are interested to know how study trials are designed, you can have a look and read through the papers. Yeah. So if you notice, the initial power calculation, they actually required probably 10% of patients to have 90% power. But they increase it to 20,000 patients. But by the sample size, they increased at 13,000 when they actually found out that they want to change the primary outcome from in-hospital death to 28 days and limit the hours to 3 hours compared to 8 hours. Yeah. So to prevent all their effort wasted or collected data that collected initially was not used, they actually had to amend. And I'll explain later why they need to change. Yeah. All right. Okay. So, and they decided to actually sub-analyze the patients because we know that traumatic brain injuries actually can classify to different severity. Okay. So the rest we mentioned before. And then now we look into, so this one in CRASH 3, they collected in 175 hospitals in 29 countries. So they took about 7 years to get all the data. And the analysis actually take longer. All right. So the inclusion criteria was adults with traumatic brain injury within 3 hours of injury. So if you noted, the study actually started in 2012, but in 2016 onwards, they actually changed from the hours of 8 hours of injury to 3 hours of injury. And their GCS, this is the lowest line. If you remember, in CRASH 1 and 2, their GCS is less than 14, whereas in CRASH 3 was GCS less than 12, or ability to get a CT that shows that patient has intracranial bleeding, right? And the patient must have no major external bleeding because remember, CRASH 3, they want to emphasize on traumatic brain injury patients only. And then the treating clinicians, same, be uncertain whether it's appropriate or not. All right. So in the 12,000 patients that they randomized, they actually found out that there's a low percentage of patients withdrew, and there's low percentage of data unavailable or lost to follow-up, which is the strength of this study. Okay, and then the baseline characteristic, or often we say the demographic of the patients, are very similar and well matched, so there's no bias in both groups, the interventional and the control arm. Okay, and 27% in the tranexamic acid group and 28% of patients in the placebo group each have a GCS of 13 to 15. Therefore, it tells you that these patients were still recruited because they have a positive CT scan report that shows that they have an intracranial bleed. So why they change from 8 hours to 3 hours? If you were to look at this diagram, they differentiate the patients into a mild moderate GCS score with a severe GCS score. And then they notice that the risk ratio, if the risk ratio is more than 1, is actually an unfavorable outcome. So by the time 180 minutes, which is about 3 hours, is already unfavorable. So in order for this trial to continue, they change it to 3 hours. Okay? Whereas in the severe GCS score, from the beginning to the end, it's already unfavorable. So they actually mentioned that in this study, the patients are sicker, which means whether we treat or we don't treat, eventually the patient's outcome is the same. Okay? So, very simple, same as CRASH 2. So they just give 1 gram of tranexamic acid over 10 minutes, followed by an infusion of 1 gram over 8 hours, whereas the placebo group used normal saline. Yeah? So the primary outcome, actually the 28 days in hospital head injury associated mortality in these patients within 3 hours, there's no significant difference, okay? Between the tranexamic acid, if you notice, is 18.5%, whereas in the placebo group is 19.8%, with a relative risk of 0.94, with an absolute risk reduction of 1.23%. So this is what I mentioned to you. So actually, when they find out, okay, this is the line that we says whenever you have any studies or data, the square boxes, the size differs because it shows you the amount or sample size. The smaller the box it is, the lesser the sample size. The bigger it is, the more it has. And once they cross this line, which means that it's not a favorable outcome. So anything that beyond this vertical line shows that it favors tranexamic acid. So they claim that patient with a severe traumatic brain injury with GCS less than 3 or 8 actually dilutes the sample. Because these patients, they argue that if you look at the graph that I showed you just now, be it at the first 1 hour, 2 hours, 3 hours, their outcome is actually poor in the beginning to say. So actually, they are the poor outcome. So it's not fair for them to include in this trial to dilute the result of your statistic. Hence, they decided to actually make this statistical analysis to subgroup. And hence they change the time from 8 hours to 3 hours. Yeah. So because of these results, the overall result still says that it favors tranexamic acid. So that's why in the beginning I say CRASH 3 was almost a negative study. However, they managed to sub-analyze it and still show some benefit. Okay. So this is just in words, whatever I just mentioned. Yeah. So the secondary outcome that in timing of tranexamic acid. So in less than 1 hour, the relative risk is 0.96, whereas within 1 to 3 hours, the relative risk is 0.93. So they are trying to say that early treatment is more effective than later treatment in mild to moderate injuries with a p-value of less than 0.005. So it's statistically significant. Next, the disability measures. They actually measures how the patient is, their disability after the traumatic brain injury. Okay, so the good part about the tranexamic and placebo group is their disability are similar. Okay, so the complications, they were also able to show that the complications, there's no increased risk of vaso-occlusive events in both groups. So this is the busy data, but if you have a quick glance to compare between the tranexamic and placebo group in all, if you look at the last uh, last column and row, they are almost the same. Okay. All right. So the strength of CRASH 3 tell us that same, they recruit many hospitals. So, and all these hospitals range from the low income, middle income, high income group, and it's a multi-center. So you cannot say there's bias or there's some manipulation to the data, all right? And there's a good internal validity, which means they have minimized the selection bias, they randomize, they have a protocol, and they have actually a very low or loss amount to follow up, because you imagine if there's about 10,000 studies sample size, you only lost 25 in each arm is actually very low. They are not significant to have an impact on your result. Okay, so a pragmatic design, which means it's a very good design that in clinical that really helps the patient, and they allow timely access to intervention, which means they can carry it out and they can actually intervene and they can collect the data within the time. All right. And they use GCS because in middle or low income group, probably you cannot get CT scan that quick compared to in a high income group like USA. Hence, that's why the inclusion criteria was either one. Yeah. Okay. And the study also actually considered patient-focused outcomes, which means they actually see the ability and not just mortality, because we're already moving away from just keeping patient alive. We are trying to actually bring the patient back to baseline functional status as much as possible. So this is a demographic that shows that there's no bias. If you compare between the tranexamic acid group and the placebo, they are almost literally the same. Okay. However, there's definitely weakness in CRASH 3 trials. They claim that the primary outcome where they actually document only the 28 days in hospital head injury associated mortality could miss certain cohorts. Example, patients that actually discharged to nursing home earlier or patients that bring back home earlier, and whether they actually survive after that or not, this may not be accounted and not updated to them. All right? And the classification of the primary outcome by the responsible clinician may lead to some errors in classifications, which means based on the GCS, a different clinician probably give a different GCS, another clinician probably give a different amount of GCS on the same patient. Okay? So these differences may lead to what we call a recall or observer bias. All right? And there was no mention made about pre-hospital interventions, whether the patient was hypoxic or not, whether CPR was done or not. All this were not documented. So these are called the weakness. We won't be able to tell. So in summary, CRASH 3 trials, they actually tell you that when you give tranexamic acid within 3 hours of injury, they actually have a mortality benefit in patients with acute traumatic brain injury, provided they belongs to the mild to moderate group. All right, and they claim that this tranexamic acid has no significant increase in vascular occlusive events. Okay, so last, I just want to show this summary of meta-analysis. So you can see that CRASH 2 and CRASH 3 actually shows that our practice that tranexamic acid favors a patient's outcome. All right. Hence, that's why in our practice we actually use quite often tranexamic acids. So that's all. Thank you very much.